Benzos. Okay, so I've already talked extensively about them in the sedative hypnotics parts. I won't go into their individual properties, kinetics, side effects, all that. What I want to focus on is their general use in epilepsy, and that is in status epilepticus. So that's a specific syndrome that is, well, the definition is simple. A seizure that has been going on for at least 5 minutes. Although, generally, you don't want to wait 5 minutes before you start treating because by then, the seizures might have already led to damage in the brain, okay? So this is, of course, different from, I just need to clarify because there's been a lot of controversy here. A lot of anti-psychiatry people on Twitter have been saying that, okay, ECT causes seizures, so therefore it can cause brain damage. That's not true. It's a very different kind of thing. Okay, so ECT and the seizures here, they're different things. ECT really is a great option for severe catatonia, refractory depression, but this kind of seizure has been going on for a very long time. That's a very different thing altogether. Okay, and for that, you want to give drugs. And our first line, mainstay for that, would be the benzos. Now, this is a very interesting board exam question that, I use as my textbook example of why worshipping board exam questions can lead to poorer practice. And why is that? Because, as of, when I asked, generally, the answer na binibigay sa akin for boards daw is either diazepam or lorazepam. IV diazepam, IV lorazepam, one of the two. Lorazepam is in the Philippine National Formulary, but technically it is not FDA registered. So practically speaking, diazepam is the one that's registered in the PNF and it's recommended actually. But do we have superior options? I think it's already clear. It's displayed above me. It's in the forest plot here. This is my favorite trial to cite because this has been since 2012 and the recommendations from the American Epilepsy Society have not changed. Midazolam is at least non-inferior to IV lorazepam, and it could even be potentially superior. If not in efficacy, because again, maybe the study was not designed to test for superiority, okay, fine, that's fair. But if not in superiority, then in the fact that it is intramuscularly administered. It can be difficult to establish an IV line immediately when there is an emergency and, the stakes are high, there could be a bit more panic. IM, literally just inject it into the muscle. You're done. Plus, at the same time, there are temperature considerations for IV lorazepam as compared to, say, IM midazolam. IM midazolam does not require temperature considerations. IV midazolam, you need to consider temperature when storing it. So it's a lot easier, actually. It is less difficult to use IM midazolam. So in practice, technically, first line has been, for at least a decade already, IM midazolam. IV lorazepam and diazepam are technically acceptable first line, pero preferable din sana ang IM midazolam. But fine, for the boards, just answer whatever they tell you is the board exam answer. Because the goal there is just to pass, right?